all hear me? Okay, great. Thank you for your kind invitation, and I'm really delighted to be here. This is my first trip to this city, and I still have to discover and see what I have got myself into. So thank you for the invitation, and what I'm going to talk today is to summarize the current challenges associated with the diagnosis of breast cancer in distinction between carcinoma in situ and atypical ductal hyperplasia, define a rationale to abandon the term of carcinoma in these cases and replace it with borderline breast disease, and discuss different strategies for clinical management and long-term follow-up of the patients with borderline breast disease. Let's just talk about why there is such an emphasis on low-grade ductal carcinoma in situ. The reason that it has become a very common disease because of screening mammography and increased number of image-detected biopsies, the number of atypical proliferative lesions as well as carcinoma in situ naturally has increased tremendously across the board. And the distinction between atypical ductal hyperplasia of low nuclear grade and atypical ductal hyperplasia has remained to be a diagnostic challenge for pathologists all over the world. And there are more chances of overdiagnosis and underdiagnosis of these entities, which naturally leads to a different kind of therapy, meaning that we may be dealing with significant number of overdiagnosis and underdiagnosis, which naturally impact cost, and of course, there are significant amount of anxiety to the patients. So let's just try to remind ourselves as what is breast cancer. And when we look at a very, very simplistic version of how breast cancer develops, it appears that from the time that the normal epithelial cells become an invasive cancer, it undergoes a cascade of events from hyperplasia to atypical hyperplasia to carcinoma in situ and invasive cancer. And for a breast cancer to either to be palpable clinically, or we can find it by breast imaging, there are significant number of biological and cellular and molecular changes that occurs in that individual cell. And it is natural to believe that if we have a fantasy of eradicating breast cancer, we need to really pay attention to precursors and try to see if we can define atypical hyperplasias that they are prognostically significant and they may evolve to invasive cancer, and try to really entrap that cycle so we do not see invasive cancer. When the cancer becomes invasive, which has the potential to metastasize, that is practically too late. We need to really become a little bit more concerned about finding the precursor lesions and try to intervene at the right time. And then when we look at, again, the same concept into a different version of it, we understand that from a normal ductal epithelial cells, that they are lined by one epithelial cells and they are surrounded by myoepithelial cells as a supportive cells for the ductal element. It undergoes hyperplasia, atypia, and then ultimately carcinoma in situ. And this progression also depends on the balance between the proliferation, which is the amount or the degree of cells to proliferate and double itself, and apoptosis, which is the degree of cell death and individual cell necrosis. Therefore, there is also balance between estrogen receptor and Ki67, which is a reflection of the proliferation. So the balance between the two is the state of the health of normal epithelial cells. When that balance changes, which changes over that progression, we can see that the relative risk for breast cancer increases from 1, which is normal status, to all the way to 10 to 20 when we are calling something carcinoma in situ. So looking at ductal carcinoma in situ is a heterogeneous disease characterized by neoplastic proliferation of ductal epithelial cells with no evidence of a stromal invasion. And as you can see that individual cells or individual ducts are confined to their ductal elements, but they are naturally increased in the number. Determinant of tumor behavior in carcinoma in situ depends on the morphological features of ductal carcinoma in situ. And as you can see in here, ductal carcinoma in situ can present differently based on the nuclear grade, presence or absence of necrosis, and the pattern of presentation. For example, a low-grade ductal carcinoma in situ of cribriform type is very different from an intermediate or high-grade ductal carcinoma in situ. And the micropapillary variant of, for example, ductal carcinoma in situ, they are associated with multiple, to appear as a multicentric, multifocal disease, and they have a tendency to have lymph node metastasis very early on. So ductal carcinoma in situ is not, again, the same disease and really present differently morphologically, biologically, and based on clinical outcome. And of course, when we talk about ductal carcinoma in situ that is associated to be present all over the breast as a multicentric or multifocal disease, then we are really talking about something totally different, that just a local removal of that focus of ductal carcinoma in situ does not really make a difference, because you do lumpectomy in one side, and 6 months there is recurrence and there are more tumors to appear. So it's important for us to understand the nature of ductal carcinoma in situ, to see what grade they are, whether they're associated with necrosis, which is representation of the proliferation, and what are the growth pattern upon which the biology and the outcome of the patient can be predicted. What is the molecular biology of ductal carcinoma in situ? High-grade lesions are often associated with unfavorable biological markers, genetic alteration, and loss of heterozygosity at various chromosomal loci or according to the type and the grade of ductal carcinoma in situ. And low-grade lesions are associated with what we call it low nuclear grade breast neoplasia family. And this is this category of proliferative or atypical proliferative lesions with associated tendency to call it low-grade ductal carcinoma in situ. They belong to a family that they're all associated with good outcome, and those are the lesions that we can recognize and try to make sure that we spare them from an aggressive cancer therapy. And this is a sort of pretty much a summary of what this low nuclear grade family of breast neoplasia really looks like. And when we look at this, these are practically lobular neoplasia, low-grade ductal carcinoma in situ, atypical hyperplasia, flat atypia, and all of these lesions that they are both morphologically as well as by molecular genetic testings, they have common and they share similar biological features. If you lump them all together, they belong to that category, that they are associated with good prognosis. And if they are diagnosed, perhaps the best thing with that is to sort of excise the lesion and follow up the patients, because these people, even when they evolve into becoming an invasive cancer after 15 or 17 years of follow-up that they are in the literature, these tumors of low nuclear grade, tubular carcinomas, well-differentiated cancer, that they have very little propensity or ability to metastasize and claim somebody's life. And it's very important for us to really keep that in mind and understand that ductal carcinoma in situ are really different. High-grade lesions are genetically different and should be viewed and treated like an invasive high-grade lesions. Low-grade lesions belong to this category that we need to recognize them and make sure that our clinician understand that and the patients understand that. Let's take a moment and talk about columnar cell change that has become a sort of a fashionable disease, and we are diagnosing them more since they have been sort of described as an entity. And of course, columnar cell change has been really around for a long, long time. They have been called differently. They have been called columnar cell lesions, columnar alterations with prominent apocrine snots and secretions, atypical cystic lobule, clinging carcinoma, and lately flat epithelial atypia. Now, when we look at the outcome studies of cases that they have been called flat epithelial atypia, Dr. Giuseppe in Italy was the first one who would call this kissing carcinoma or clinging carcinoma. And in this situation, when they have really looked at long-term follow-up of the patients that they have been diagnosed with this atypical columnar cell change or flat atypia or clinging carcinoma, in its own, if there is no associated atypical hyperplasia or any other lesions, these lesions after 19 years and 5.4 years of follow-up, they have not shown themselves to evolve into an invasive cancer. So again, these lesions are, for practical purposes, they are not associated with an aggressive behavior, and that is association with an invasive cancer. Now, we have an indirect evidence that they may be associated with precursor lesions, and that is because of the association of known atypias, such as lobular carcinoma in situ, ductal carcinoma in situ low grade, and tubular carcinoma, as we talked. There are loss of heterozygosity comparable to adjacent atypia, and they have common biomarkers and oncogenes, such as ER and PR, cyclin D, and BCL2. Another question that is always in being asked is, if you call something as flat epithelial atypia on core needle biopsy, do we need to surgically remove that lesion? And the answer is really based on these studies that when they have looked at diagnosis of flat atypia on core needle biopsy that they have been followed by surgical biopsy, these are the rate of upgrading of the concept, meaning that they have seen either in situ or invasive lesion of low nuclear grade in surgical excision at ranges between 13% to 20%. So in the absence of any other breast imaging abnormality or any risk factor in a patient, if this is an isolated area and they're being really recognized by the microcalcification, we may just follow the patient. But if there are multiple other calcified area and there are some breast imaging abnormality, it is best to really follow that case with excisional biopsy and make sure that we are not missing an associated lesion of lobular neoplasia, low-grade DCIS, and tubular carcinoma. Now, when we look at this cascade of events of precursor lesions and ductal carcinoma in situ, the difference between calling something atypical ductal hyperplasia versus low-grade DCIS is that precursor lesions, meaning ductal carcinoma in situ, they may be a direct precursor of an invasive cancer. They are slow in progression, and if they develop an invasive cancer, they're often low-grade in nature, as I indicated. And risk of invasion is limited to ipsilateral breast, and generally the same quadrant and site. And that's a very important component of it, because these kind of lesions, by some people, they are being recognized as a sort of a segmental and focal disease rather than a sort of a systemic problem. Whereas when we talk about morphologic risk factors such as atypical ductal hyperplasia, that indicates increased risk to both breasts, and it is not a direct precursor of lesion, and of course it's difficult to distinguish from low-grade ductal carcinoma in situ. So they are biologically different, the way that they present they're different, and actually as far as the therapy they're different, so that distinction becomes important. Why we as pathologists have such a difficulty to make that distinction? Is it because we don't really understand it? Is it because we don't pay attention? Is it because we just don't want to take responsibility toward this diagnosis? And the really answer is sort of a multiple factors, but the most important factor is ambiguity, confusion about even what atypical ductal hyperplasia is. The initial definition of atypical ductal hyperplasia was an entity which has some but not all the features of low nuclear grade ductal carcinoma in situ. And you can understand that by this term, you're just giving the responsibility to whoever diagnoses this case to try to make that judgment as whether this is the full picture of ductal carcinoma in situ, or this is just a part of the process. So with that in mind, the adherence to morphological criteria that has been described is naturally a very important part of the process. And we have Page and Anderson in 1987 that practically defined the term of ductal hyperplasia. And they indicated that if we have two ductal systems that are completely effaced in a single terminal duct epithelial lobular unit, they are monomorphic, they have non-polarized epithelium, they have the cribriform bridges without attenuation, and they have these uniform lacunar spaces that you see in here, then this is atypical. This is low-grade ductal carcinoma in situ. And then we have Dr. Tawassoli and Norris' definition of the same thing, that they bring quantitative measures, and they say that this abnormality should be seen in minimum involvement of two duct spaces, and then sums of diameter of that duct, which is involved with this atypical proliferation, must be more than 2 millimeter. And of course, you can understand that majority of these investigation has been done on surgically excised breast biopsies in the past, which the pathologists had at least access to take a look at the entire lesion, and these quantitative measures would make a difference. Whereas right now that we are making these diagnoses on minimally invasive procedures such as fine needle or core needle biopsy, it is very difficult to really quantitate these and have the same accuracy. Now, let me bring you to another challenge that we as pathologists have, and that is the presence of this significant inter-observer variability, meaning something that I may call atypical ductal hyperplasia. The next pathologist may call it low-grade ductal carcinoma in situ. This is the original article by Dr. Rozai in 1991, who looked at sending a number of these difficult-to-diagnose cases to 5 pathologists. It was 10 cases. And then he looked at the agreement among the participants, and these were expert breast pathologists. And you can see that the level of agreement is 0 among the people. 4 out of 5 agreed in only 20% of cases, and 3 out of 5 agreed in 50% of cases. And you can see that in none of the other comparative analysis, both in industry as well as medicine, that is not an acceptable agreement. This is actually very, very concerning. So this is the most cited article in the literature. So some other investigator, they came and said that, well, we need to increase the number of cases and then send it to more number of pathologists and see what happens. This is Dr. Schnitt, who authored this study. And again, even with increasing the number and increasing the number of cases, you can see that the agreement between, again, expert breast pathologists is only 58%. And this is truly like flipping a coin. Once again, this is not really acceptable. And lately, you all probably have seen the study which was published in JAMA, and that was, again, a very inflammatory article which was published, and they talked about there's only 75% agreement in difficult to diagnose breast cancers, which still is inflammatory. People talk about that. And College of American Pathologists has taken a position that this is the flaws into design of that study, and this is not what is happening. But in reality, we as pathologists have difficulty to make that distinction. And then this, again, is very important in respect to the patient care, because that clarity, when it is not present, and occasionally I see patients that they come with the same disease, the same biopsies in 3 different institutions, that it really has 3 different diagnoses. They're all saying the same thing more or less, but it's very difficult in difficult terminology, and we'll talk about that. So this is an issue that we have to be very concerned about. We did a study some years ago to try to say that, okay, if morphologically we have difficulty to make this distinction. What if we do some biological studies and see in a simple term whether they can help us? So this is a study that we did, and we look at a couple of biomarkers like BCL2, ER, PR, DNA haploidy, Ki67, HER2/oncogene, and P53, and apply them to atypical dichroic hyperplasia, low-grade DCIS, intermediate and high-grade DCIS. And you can clearly see that high-grade ductal carcinoma in situ's pattern of biomarker expression is very different from the rest. They are often HER2/oncogene positive, hormone receptor negative, they have high proliferation rate, whereas in low-grade and atypical dichroic hyperplasia, they're often HER2/oncogene negative, hormone receptor positive, and they have low proliferation rate. And you can also see a similarity between low-grade DCIS and atypical dichroic hyperplasia. So looking at biological features seen in ductal carcinoma in situ versus atypical dichroic hyperplasia, that again cannot really help us. So that has led to the question that has been in the mind of a lot of people, and that is it possible that atypical ductal hyperplasia and low-grade ductal carcinoma in situ are in reality representation of the spectrum of the same entity? And as a result of that, there has been a different morphology or criteria or terminology that has been proposed. Intraepithelial mammary neoplasia was proposed by Dr. Rosai in 1991. Dr. Tavassoli had brought the concept of ductal intraepithelial neoplasia, which unfortunately had not been really received with significant interest among at least United States pathologists. And then we have low nuclear grade breast neoplasia family that is coming from United Kingdom and the other people, that again has not really become a sort of a standard of terminology that is being used. So none of these things are really being used on a regular basis, and people have stayed with the terminology of low-grade DCIS and high-grade DCIS, and the process continues. When we look at what is the opinion of really experts in this area, is there any light at the end of the tunnel? This is the quote from Dr. Rosen, who is distinguished really surgical pathologist and incredibly outstanding breast pathologist. And this is what he says. He says that there is no consensus presently on the criteria that should be adapted and how they should be applied for the distinction between atypical hyperplasia and carcinoma in situ. Morphologic criteria for the diagnosis of atypia, implying increased risk for cancer risk, and in situ carcinomas may be improved when it is possible to relate these proliferative lesions to specific genetic and biochemical markers. Therefore, in that scenario, when we look at again the history of the distinction between atypical ductal hyperplasia and low-grade ductal carcinoma in situ, we understand that it really is a diagnostic challenge, not only on fine needle and core needle biopsy, but even in surgical biopsy. And to me, I think this entity is just like photography. I think in order to have a good picture, not only you have to have a good photographer, a good camera, and a good light, you have to have a good subject. You cannot really make a sort of a non-attractive individual to become beautiful by having all of these components associated with that. And I think atypical ductal hyperplasia and low-grade cancer and these atypical proliferative lesions of the breast are entities that we really do not know what they are. That's the reason that we have such a difficulty to make that distinction. And unless we come across something that it would help us, that is what is going to happen, and this is where we are going to be. Let me share with you the story of a patient, and these are real cases. This is a self-referred, newly diagnosed breast cancer patient who is scheduled to undergo mastectomy and lymph node dissection. The patient was 32-year-old, no risk factors, and she discovered the mass when she was showering. The breast was sampled with core needle biopsy and was diagnosed as an invasive cancer. A palpable lymph node was also sort of felt, and the clinician assumed that is a metastatic disease. And the patient was advised to have mastectomy and axillary dissection, followed by chemotherapy. And this is the histology of this core needle biopsy. And this is what it was called: invasive moderately differentiated ductal carcinoma and low-grade ductal carcinoma in situ. So we looked at this case in our institution, and just looking at this, it appears that this is nothing but just a florid sclerosing adenosis and apocrine adenosis. And we did a myoepithelial marker, and epithelial marker were all positive. Myoepithelial cells are very interesting, marker. When there is proliferation, they come along and they participate in that process of proliferation. When it becomes cancer, they just step back and they say, we are supporting organism, we cannot participate in that. So you do not have participation of myoepithelial cells in anything that you look at. And myoepithelial cells are very easy to distinguish. You have myoepithelial cell markers such as P53 or calponin, and they define them very, very easily. And you can see the brown staining or reflection of the staining of the cells by myoepithelial cells, showing that this lesion by no means can be an invasive cancer. So our advice to the patient was the fact that there will be no mastectomy in this case and no axillary dissection, because we did a fine needle aspiration biopsy of the lymph node, which was really reactive and nothing there. So we advised the patient, let's go into a wide excision and a normal remove the breast tissue around it and take a look at the whole thing and see what we're dealing with. And this is exactly what the surgical excision showed. Again, proliferative lesion, apocrine adenosis, and that was diagnosed and confirmed by myoepithelial cell immunostaining for that. So then the original pathologist in another institution challenged us and said that, well, why don't we send this case to another consultant? I said, by all means, we will send it to 2 consultants and see what is happening. So we sent this case to 1 consultant in east part of the country and 1 consultant in the California area, and we led them to make a diagnosis on this case. And this is diagnosis number 1, atypical apocrine adenosis with sclerosis and associated florid sclerosing adenosis. Consultant number 2, call it low-grade apocrine ductal carcinoma in situ with focal sclerosis, preductal and radial involving radial scar, preductal and radial involving multiple cores. So as you can see that this was a patient was diagnosed with invasive metastatic breast cancer, and then this is being seen by 3 pathologists. I practically call it atypical apocrine adenosis and really no indication of low-grade DCIS. So, and this patient was the one that we did excisional biopsy, and there was no associated more severe lesion in that. And then in that scenario, we sat down and talked to this patient. And this is the patient, naturally relieved and surprised and confused. And we told her about all these diagnoses, we told her about the complexity, and we told her that either we can just follow the patient as it is because there is no evidence of any, cancer in the biopsies, or we can take it as ductal carcinoma in situ. If the patient wants, we can do radiation therapy and whatnot. The patient decided to just undergo excisional biopsy, follow-up. Make the story short, the patient stood in this concept for almost about 8 years. And after 8 years, he went to New York Times, and there was a story about the whole concept of overdiagnosis of these lesions. So in New York Times, one day, this article appeared, and I was there talking about that we have a problem, and then distinction between these 2 entities still remain a problem. So it brought a lot of attention to the media and scientific community, but the whole question that we're asking is whose fault it is. And if this patient has not really come and tried to get a second opinion, the patient may have lost the breast and would be diagnosed by, say, same pathologist in the same hospital as invasive cancer. And can we do better? So I think I'm out of time, and I'm going to just not to talk about all of these things and then talk about our suggestion. We need to acknowledge the challenges associated with care and practice of breast pathology and to design studies that can appropriately analyze the problem and quantitate that impact on therapy, patient outcome, and health economy. We have to establish quality assurance program, both internally and externally, and we have to make sure that these breast cases, difficult to diagnose cases, are being viewed by more than one pathologist so that we can get the wisdom from several people. What we do in our institution, we have abandoned the term of low-grade ductal carcinoma in situ. We call them borderline breast disease, and we advise the clinician completely remove the entire lesion and offer risk assessment and risk reduction modality. This offering of wait and see what happens is the same concept that has been really going on with prostate cancer for many years, and it has worked. So we may have to adapt some of those strategies in breast cancer. The impact of what we are trying to do is to reduce the anxiety to the patient and family, minimize unnecessary expenses, and of course restore the patient trust in our system. So the distinction between these two entities are still a problem, and hopefully we are going to be in a position in years to come with better molecular biology and better technology and imaging, we would be able to really change this pattern. And of course, I'm not going to speak about that. And to finish that, there are over 1.1 million women that are diagnosed with breast cancer across the globe. Even we look at estimated diagnostic errors of being only 2%, you can understand that how many women across the board can undergo over and under diagnosis. So there is a plea for a standardization of this practice and improve the quality of breast pathology. And hopefully, if we do that, our work in breast care as a multidisciplinary team should be like an orchestra. We should all sing the same song, and that is not what is happening now. Thank you very much for your attention.
Thank you very much. Thank you very much for your very clear lecture in what is clearly a very difficult area. I now call on Peter Whiteman, I think, to present the certificate of the keynote speech.
I need to say that?
1 minute. We're going to get a certificate.
Okay. Congratulations.
Thank you very much.
Nice.
I didn't expect this one. Thank you.